Hello, I'm Lauren McCafferty, and I'm an ultrasound fellow at University Hospital's Cleveland Medical Center. I'm doing a series on the use of point of care ultrasound to augment what are traditionally considered landmark based procedures. To start things off, I'll be discussing lumbar puncture in this video. Before I move on, a couple quick disclaimers. When I talk about ultrasound guided LP, I'm referring to static guidance rather than dynamic guidance, which is the typical way that we use ultrasound for procedures. Here, we'll be using ultrasound to identify the anatomy, mark the skin, and then using those markings, you would proceed with the LP as you normally would without the use of ultrasound. So you're not visualizing the needle in real time. The other thing is that I'm going to focus primarily on the ultrasound component, not the procedure itself. Why use ultrasound for this? The obvious answer is that you can better visualize anatomy. Sometimes you might get lucky and can easily identify a patient's landmarks with palpation or even direct visualization. You know exactly where to place the needle, and you can do the tap no problem. However, we all know that it's not always that easy. At some point, if you haven't already, you'll have a patient that looks something like this, where you can't even come close to reliably identifying anatomy despite optimal positioning and deep palpation, even if you do it multiple times. This is an example where ultrasound to better visualize anatomy can clearly be an advantage. In addition to obesity, another patient factor that might encourage you to use ultrasound is someone with abnormal anatomy. This could be someone with a history of scoliosis or degenerative disease, or really anything in which the anatomy is disrupted in some way. While these groups of patients may be obvious ones for which you should consider ultrasound, the evidence suggests that ultrasound is actually advantageous in any patient. This was a systematic review and meta-analysis from 2019 in which a total of 12 studies, all prospective randomized control trials with just under 1,000 patients, were ultimately included. They were comparing ultrasound-assisted or static guidance LP versus a landmark approach LP, which one had a higher success rate. In addition to finding out that ultrasound-guided LPs had higher success rates, they also found that the use of ultrasound was associated with fewer traumatic LPs, shorter time to successful LP, fewer attempts, and lower patient pain scores. So overall, this was a win for ultrasound-guided LPs. The general technique. You're going to optimally position your patient. This means placing them in whichever position you plan to do the procedure. It's very important to minimize movement of either yourself or the patient, as any movement could easily throw off your anatomy and make the use of ultrasound essentially far less useful. In terms of probe choice, you can use either the linear or the curvilinear probe, whichever you prefer, though in larger patients, a curvilinear probe may be your only option. I personally prefer the curvilinear probe just because it gives you a better view of your entire field and the surrounding anatomy. Always scan in both a long and short axis. I'll go into more detail about that in the coming slides. And finally, the overall goal when you're doing this is to identify the optimal location for needle entry. Just a brief review of the lumbar spine anatomy. On the left is a sagittal view, and the right is a posterior coronal view. The main landmarks you'll be looking for on ultrasound are the spinous processes. These are going to be your guide for finding the intervertebral spaces, which is where you'll be directing your needle. Your first goal when doing this is to identify the midline. You'll place your probe in a transverse orientation over the patient's lower lumbar spine. The probe marker should point toward the patient's left, since you're standing behind the patient. That way, when you move the probe left on the patient's skin, the image on the screen will move left as well. It just makes it easier. You're going to get something that looks like this. This is a cross-sectional view of the patient's spine that's essentially an upside-down version of an axial CT or MRI. And the reason I say that is because structures here at the top of the screen are going to be more posterior on your patient, whereas structures at the bottom of the screen are more anterior on your patient, the opposite of that of an axial CT or MRI. So you're mainly looking for the spinous process, which typically shows up as a hyperechoic rim with clear shadowing behind it. This is not the best example of a clear spinous process. I'll show you a better example in just a second. But here, I just wanted to point out kind of what the overall anatomy is. You find the shadowing behind the spinous process. You line that up in the middle of your screen. That's your midline. And then if you look on each side, you can see the paraspinal muscles, then the lamina extending out from the midline, and then the transverse process beyond that. For reference, this is the anatomy that you're looking at. This is a better example of a clear spinous process. There's the hyperechoic rim with a clear posterior shadowing behind it. Again, this is your midline, so you want to center this on the screen, and once you do that, you're going to make a mark on the patient's skin in the center of the probe. Once you've done that, your next goal is to identify the intervertebral space. So you're going to take your probe from the transverse view, rotate 90 degrees clockwise, so the probe marker is now pointing toward the patient's head. Remember the midline that you just marked off and keep your probe directly over that midline. That way it will ensure that you're directly over the spinous process. This is what you'll see. There will be multiple spinous processes that appear as bright hyperechoic arcs with shadowing behind them. You'll be able to tell which spinal level you're at based on the relation to the sacrum, which will have a very different appearance from the arc-like structure of the spinous processes. So once you find your sacrum, you'll count up from there. So here, the sacrum is going to be on the right of the screen. It's not very well visualized, but then the arc in the center of the screen is going to be L5, and then the one on the left to that is L4. So once you find that, what you're really looking for is the intervertebral space, which is the space between the spinous process. This is going to be where you're going to direct your needle. And this is what it will look like using a linear probe. This was a slightly thinner patient. You can see that you don't get quite as good of a view of the surrounding anatomy, but you may get better resolution. And you can still see the spinous process as a hyperechoic rim with shadowing behind it. You can see that on either side of the screen here. And then the space between is your intervertebral space, which is where you'll be directing the needle. Once you find an intervertebral space, you want to slide your probe slightly superiorly or inferiorly while staying on the midline and mark the patient's skin in the middle of the probe. Ideally, you'll identify and mark off multiple intervertebral spaces so that you have multiple options in the event that the first attempt doesn't go so well. Once you've made both your horizontal and vertical marks, extend them until they form a cross. These cross sections are then going to be your targets for needle entry. One more thing you can use ultrasound for is to estimate depth to the subarachnoid space. So remember that this isn't perfect and it's only a rough estimate, but it is useful in helping you decide how long of a needle you should use and about how deep the needle should go before you should expect to see some CSF. Back to our long axis view. So you see the spinous processes, the intervertebral space between them, and you'll notice as you look at the intervertebral space and move slightly anteriorly, so down the screen, you'll notice an abrupt change in echogenicity right about here. So this is your ligamentum flavum, and this is what will elicit the pop as you're getting into the subarachnoid space. So you'll measure the distance between the patient's skin and the ligamentum flavum. And notice that this is slightly angled because, as you recall, when you do an LP, you want to direct your needle toward the umbilicus, so at a slight angle, rather than entering the skin at completely 90 degrees. In your short axis view, you're going to actually slide slightly superior or inferior off of the spinous process, so that way you're able to see structures more anteriorly or deeper. So here you can actually see part of the vertebral body within that shadow. You again see the lamina, and the spinous process is even less clear than it was before. And now you're looking for the area right about here, where again there's a slight change in echogenicity. A third view for estimating depth is by using the lamina, which is a new view. So you're going to go back to your long axis view with the probe over the spinous processes, and then you're going to slide the probe slightly left or right off of the midline so that your probe is directly over the lamina. The lamina will appear similar to the spinous process in that it's a hyperechoic arc with shadowing behind it. The difference here is that the lamina are more closely approximated, so there's less space between the lamina. Also, the lamina are going to be deeper on your screen than the spinous process because the lamina don't extend as far posteriorly as the spinous process. And additionally, you'll notice here that there's a large muscle with its longitudinal fibers running above the lamina, and this is your paraspinal muscle, which you shouldn't see with the spinous process. Here you're going to measure the distance between the patient's skin and the lowest point between the lamina before you hit the shadowing. This is another rough estimate of the distance to the subarachnoid space. A few pearls and pitfalls. Remember that this may not be perfect. While you use ultrasound to help better visualize the anatomy, you might still have poor visualization, especially in people with larger body habitus or abnormal anatomy, so that you can't really get a good sense of what you're looking at. Mistaking anatomy. This can happen for a variety of reasons. It could be that you just haven't done this very much and you don't really know what anatomy is supposed to look like with ultrasound. It could be that you do have plenty of experience, but your probe is slightly off midline and you accidentally mistake the lamina for the spinous process. It could be that you're fanning your probe slightly and not perpendicular to the skin, which will throw everything off a little bit as well. So just be aware of the potential to mistake anatomy. For this reason, make sure your probe is perpendicular to the skin. This would be one example where fanning would not be helpful. As I mentioned before, it's very important that you minimize movement of both yourself and especially the patient, as any sort of movement could easily throw off your ultrasound markings and make the ultrasound guided component of this far less useful. One way to minimize this is to make sure everything is ready at the bedside before you even put the probe on the patient. This includes making sure the patient is calm, as comfortable as possible, and all of your supplies are laid out and ready to go. Some general take-home points. Remember to scan in 2 planes, use the spinous processes as your guide, make the marks and connect the dots. You can estimate depth to the subarachnoid space using ultrasound. This will help you determine how long of a needle you need to use and how deep you need to advance your needle before you should expect to have CSF return. It's just one extra step and it's pretty easy to do. Beware of the pitfalls I just mentioned. And finally, this extra step of using ultrasound may actually save time. One thing that might discourage people from using ultrasound for LP is that it's seen as inconvenient. Sure, it takes time to find the machine, perform the ultrasound, clean the probe in the patient before actually getting ready to do the procedure. It's important to remember, however, that the use of ultrasound offers several advantages, potentially some time-saving ones, over the traditional landmark-based approach. And while this is useful and beneficial in any patient, especially for those patients for whom you anticipate difficulty right off the bat, ultrasound might require a few extra minutes of your time, but may end up being a much more efficient approach in the long run. And in fact, I just recently had a patient with one of my residents. This patient was over 350 pounds, needing an LP. Admittedly, we thought for sure we'd end up having to send her to interventional radiology for the LP, but we did it ourselves. My resident used ultrasound and ended up coming very close to a champagne tap on her first attempt with this patient. So overall, It was a huge win. We ended up saving a ton of time. So I encourage you to familiarize yourself with this procedure, even if you don't have to use it every time, but it's a great tool to have. That's all for now. If you have any questions, feel free to contact me. Thank you.